A very good morning to all of you. Honorable Director Sir, Honorable Vice Principal Sir, Honorable Ex-Principal Dr. Mirza Hamidul Haq Sir, respected Professor, teachers, my senior and junior colleagues, and my beloved intern doctors. I am Dr. Sarfati Amin, Indoor Medical Officer, Obstetrics and Gynae Department. Welcome all of you in today's weekly clinical meeting. Today's meeting is organized by Obstetrics and Gynae Department, Unit 1. Topic of today's session is a mass in lower abdomen. And speaker is Dr. Mymensingh, Assistant Registrar, Obstetrics and Gynae Department. Today's session will be chaired by our Honorable Professor Dr. Shilashan Ma'am, Head of Obstetrics and Gynae Department. Now I am requesting today's chairperson to come up to the dais and conduct the rest of the session. Thank you.
A very good morning.
স্বচ্ছ শরীরে বড় না পরিণতি দূরে
জি স্যার শীতের সকালে আজকের এই মিটিং সেমিনার মিটিংয়ে সবাইকে আমন্ত্রণ জানাচ্ছি। স্পেশালি আজকে আমি খুবই অনার্ড, আমাদের সামনে আছেন আমাদের ডিরেক্টর স্যার আর আমাদের সবার প্রিয় এবং আমাদের অত্যন্ত শ্রদ্ধেয় মির্জা হামিদুল হক স্যার আর আমার সিনিয়র। এখন তো ভাবছিলাম যে সকালবেলা সিনিয়র যারা সামনে বসতেন তারা কেউ কেমন লাগে, আমার সিনিয়র কলিগস, junior colleagues, my beloved intern doctors, and my colleagues of my department. I welcome everyone to attend the session. Today's topic of today's session is mass in the lower abdomen. It will be presented by our assistant registrar of my department, Unit 1. Dr. Mymensingh come to the dais to present presentation today's session.
Assalamu alaikum and good morning everyone. Thank you Professor Dr. Shilashan ma'am for your kind introduction. I'm truly grateful to be here today. As doctors, we often encounter pelvic mass in our daily practice, but the diagnostic challenge lies in the outliers, the cases that don't quite fit into the standards. In this presentation, I will walk you through the initial clinical findings and diagnostic workup, the intraoperative findings that challenged our hypothesis, and finally, the histopathology and postoperative outcome. Now, with the permission of our chairperson, I would like to present today's case. Thank you, ma'am. Let us begin with the clinical history. Our patient, Mrs. Nurun Nahar, 42 years old Muslim housewife, hailing from Ishorganj, Mymensingh, got admitted into this hospital on 3rd January 2026 at 10:30 a.m. and she was examined on the same day at 10:35 a.m. She presented with the complaints of heavy menstrual bleeding for 3 years, feeling of a lump in the lower abdomen for 2.5 years. History of present illness. According to the statement of the patient, she has been suffering from heavy menstrual bleeding for last 3 years and feeling of heaviness and lump in the lower abdomen for 2.5 years. She noticed excessive bleeding during menstruation, which was progressively increasing in amount and duration. Previously, she used 1 to 2 pads per day, but now she has to use 7 to 8 pads per day, which gets soaked within 3 hours of wearing. She gradually noticed a mass in the lower abdomen, which was slow growing in nature for the last 2.5 years. She also complained of weakness, palpitation, and tiredness for the last 2 months. For these above complaints, she consulted with a gynecologist and was treated with oral contraceptive pills and antifibrinolytics. But she took it irregularly and her condition did not improve. She didn't complain of any significant pain during menstruation, any postcoital bleeding, dyspareunia, or low back pain. Her bowel and bladder habits were normal. With these above complaints, she got admitted into this hospital for better management. She had no history of hypertension, diabetes mellitus, tuberculosis, thyroid disorder, or any other chronic illness. She took some oral contraceptive pills and antifibrinolytics irregularly. She had no history of smoking, chewing betel nut, or taking alcohol. She had no positive family history. She belongs to a lower middle class family. She was immunized according to EPI schedule and vaccinated against tetanus. Menstrual history. She started menstruating at 13 years. Her cycle was regular. Initially, her menstrual period was 3 to 5 days long and her flow was average. But for the last 3 years, the menstrual period has been 8 to 10 days long and the flow is heavy. Her LMP is 18 December 2025 and she has not been practicing any kind of contraceptive. Obstetric history. She has been married for 25 years, para 1+0, and age of last child is 16 years. On general examination, we found her to be 5 feet, 55 kg, anxious but cooperative patient whose decubitus was on choice. She was moderately anemic, but jaundice, edema, cyanosis, dehydration was absent. Her pulse was 92 beats per minute, blood pressure 100/60 mm of mercury, temperature 98 degree Fahrenheit, respiratory rate 18 breaths per minute, lymph node and thyroid gland not palpable. On parabdominal examination, her lower abdomen was slightly bulged and umbilicus was centrally placed. On palpation, abdomen was soft and non-tender. A mass was felt in the hypogastric region, about 18 weeks pregnant uterus size, which was firm in consistency, smooth surface, irregular margin, non-tender and fixed. It was dull on percussion and bowel sound was present. On parvaginal examination, vulva and perineum looked apparently healthy, no parvaginal bleeding or discharge present. On speculum examination, cervix was healthy, no bleeding or discharge coming through the os. On bimanual examination, uterus was enlarged, corresponds with 18 weeks pregnant uterus, firm in consistency, smooth surface, irregular margin, non-tender and fixed. Left fornix was full. A mass was felt through the posterior and left fornix. Other fornices were free and non-tender. Examination of all other systems revealed no abnormalities. Salient features. Mrs. Nurunahar, 42 years, mother of one daughter, housewife, normotensive, non-diabetic, regularly menstruating woman, hailing from Ishorganj, Mymensingh, got herself admitted in community-based medical college hospital under our obstetric and gynecology department. According to her statement, she was a regularly menstruating woman with average flow and duration 3 years back. Then she noticed excessive bleeding during menstruation, which was progressively increasing in amount and duration. Gradually, she noticed heaviness and a mass in the lower abdomen, which was slow growing in nature for the last 2.5 years. She also complained of weakness, palpitation, tiredness for last 2 months. For these above complaints, she consulted with a gynecologist and was treated with oral contraceptive pills and antifibrinolytics. But she took it irregularly and her condition did not improve. She didn't complain of any significant pain during menstruation, any postcoital bleeding, dyspareunia, or low back pain. On admission, her general examination revealed that she was moderately anemic, her pulse was 92 beats per minute, blood pressure was 100/60 mm of mercury. On parabdominal examination, a mass was felt in the hypogastric region, about 18 weeks pregnant uterus size, which was firm in consistency, smooth surface, irregular margin, non-tender, fixed, and dull on percussion. On parvaginal examination, uterus was enlarged, corresponds with 18 weeks pregnant uterus, and other findings were collaborative with abdominal findings. Left fornix was full. A mass was felt through the posterior and left fornix. Other fornices were free and non-tender. Now, what could be the provisional diagnosis?
Fibroid হিসাবে কনসিডার করা যায়।
স্যার বললেন ফাইব্রয়েড হিসেবে কনসিডার করা যায় পেছনে।
Thank you, Dr. Neera, for your nice presentation.
It may be fibroid uterus. Thank you. আমি কি আগাবো? Thank you. So our provisional diagnosis was, as everyone said, fibroid uterus with moderate anemia. Our differential diagnosis was ovarian tumor, adenomyosis, pregnancy, full bladder, and mesenteric tumor. For diagnostic purpose, we did ultrasonography of whole abdomen, and for management purpose, we did CBC, urinary, RBS, blood grouping, RH typing, HbSAg, serum TSH, chest X-ray, and ECG. Her hemoglobin was 7.8 gram per dl, landing her at moderately anemic. Ultrasonography whole abdomen, which told us uterus bulky in size, 15 into 8 centimeter, and inhomogeneous echo pattern of fibroid, 7 into 7.5 centimeter, seen in the posterior fundal region. Adnexa was normal, and the final comment was fibroid uterus. For her general management, we counseled and reassured her. Correction of anemia was done with 2 units of blood transfusion pre-operatively, and decision for total abdominal hysterectomy was made as she was looking for a permanent solution. We operated on her on 5th January 2026 at 10 a.m. with 1 donor ready. Name of the operation was total abdominal hysterectomy following myomectomy with left-sided cystectomy with bilateral salpingectomy. Our paraoperative findings: a bulky uterus which was deviated to the left side, a left ovarian cyst about 5 into 4 centimeter with thick wall, a huge right-sided fibroid about 15 into 10 centimeter arising from the body and cervix of the uterus extending up to the pelvic floor. The uterus was about 400 gram and the fibroid was 1.7 kg. So the total weight was 2.1 kg. This is our handwritten operative note of that day. As you can see, myomectomy was done first, then the following procedure was done. This is the picture of the uterus, the fibroid, and the cyst wall. Another close-up of the fibroid and the uterus. So our confirmatory diagnosis was fibroid uterus with left ovarian cyst. She was given, as usual, post-operative management. On her first post-operative day, her vitals were stable, bandage was dry. Total 2 units of fresh blood was transfused pre-operatively. All specimens were sent for histopathology. Check dressing was done and drain tube was removed on 3rd post-operative day. Her wound was healthy and all stitches were removed on 6th post-operative day. She was discharged on 7th post-operative day with advice. This is our histopathology report, which said resected uterus, chronic cervicitis, leiomyoma, serous cyst adenoma. These are our histopathology slides. During discharge, her vitals were stable and wounds were healthy. In closing, while fibroids is benign in pathology, their impact on a woman's life is anything but. Our role is to offer more than just a procedure. We offer a path back to quality of life. I'm truly grateful to my department for giving me the opportunity to present this case, and thank you all for attending to this meeting.